Good morning and welcome to the 20th of our Town Hall series. I can't believe it's our now 20th anniversary of this. Give us an idea of how long this pandemic's been going, but also hopefully some of the value you've gotten from the fact that we've been diversifying what we talk about it as well. As always, I want to thank Jeremy and Caroline Finkelstein for their leadership, as well as George and Catherine Masterson of the Society for Leading Medicine. I want to thank each of you who are members of the Society for Leading Medicine and sponsoring these events. You know, this fall and last time we talked about the fact that COVID really in our market has been moving from pandemic to endemic status. And indeed, I'll show you some data. It's been a really good stretch in Houston and is a very good stretch right now. But of course, now we have, unfortunately, in a very rapid period of time, the emergence of an Omicron variant that is now kind of an asterisk on everything that I just said. And we'll be talking about that today with what we know and what we don't know, because there's still a fair amount, of course, that we don't know. We're going to actually start with Dr. Ben Weinstein, who is the chair of our Department of Psychiatry and Behavioral Health. He's going to give us a psychiatry behavioral health update, obviously something that is critically important always, but even more so of late. He holds the C. James and Carole Walter Looke Presidential Distinguished Centennial Clinical Academic Scholar in Behavioral Health, which that's a mouthful, but congratulations on that as well. So I'm looking forward to hearing from him. And then Dr. Sostman and I will come in and talk about COVID and kind of the landscape here in Houston. I also want to thank David Lumpkins, who heads up our Behavioral Health Task Force, and all the members of that task force. If today's talk really, interests you, we are always looking for other members to help support that. This is such a critically important area, and one, honestly, where I think we are on the cusp of even more impressive advances as we move forward in the future. Today we do have in the background Dr. Ashley Drews, infectious disease specialist and the head epidemiologist across our system, typing away furiously, answering all of your specific questions. So please keep her busy and take advantage of that. So first I'm going to start with Dr. Weinstein. Dr. Weinstein, it's great to have you here today.
Thank you very much. It's an honor to be here. Thank you all for joining us, and it's my pleasure to have the opportunity to talk with you about the kind of what's going on in behavioral health here at Houston Methodist. With all of our programs, there's a lot going on, and I'll try to highlight some things that I think are special and important. I want to talk for a second just about some of the impact of COVID-19 on our community. 1 in 7 Americans have been infected. 1 in 500 Americans now have died from COVID-19. 1 in 3 Americans reports significant depression and anxiety. Depression and anxiety are up 26 and 28% worldwide. That includes areas that are not even hard hit by COVID. We know that COVID and depression and anxiety are hitting disproportionate groups. We know that children are disproportionately affected, young adults, college-age students. Recently heard that the hospitalization rate for college students in our area is 4 times what it was 1 year ago. Psychiatric hospitalization. Women across all demographic groups are disproportionately affected, and healthcare and frontline workers. 1 in 5 physicians have reported depression, 1 in 4 anxiety, and 1 in 5 healthcare workers in America has quit. So it's been a tremendous impact on our field and our community. I want to talk a little bit about what we're doing here at Houston Methodist. We have several different outpatient programs that have been established here in the last 2 years. We have the Complexity Clinic, which offers 2 unique programs. The first is therapeutic assessment. This is the most comprehensive evaluation and diagnostic program in the nation. We combine medical, neurological, psychological evaluations with neuroimaging and even pharmacogenetic evaluations to help assess, diagnose, and give people a path forward to wellness. We also have a one-of-a-kind program that is designed to help treat patients with really complicated physical and mental illness that kind of have come together and left them not functioning. And we call it functional rehabilitation. And it incorporates individual therapy, group therapy, physical therapy, occupational therapy, seeing a dietitian, doing mindful movement work. And what we're seeing is tremendous restoration of function for our patients who previously their world had become very small, and many had been really either bedridden or really confined to their homes. So we've had tremendous success, and we're thankful that we're developing a growing national reputation for this work. Those programs are accepting people. We are trying to meet the demand. We have first appointments now into January and February, but we always try to get people in as soon as possible. Unfortunately, it's not covered by most insurance, which really brings us to a point that I think is worth spending some time on. In our community, if you have means, you can get an appointment with a psychiatrist or a therapist with relative ease. Once you find out who the people are, and I get many inquiries about that, I'm happy to help respond to those, you can get an appointment relatively quickly and get good care. If you have no means, we have actually reasonably good care available at the Harris Center, at Ben Taub, and at Harris County Psychiatric Center. If you rely on insurance for mental health care, you are left in the cold. There are no wonderful resources out there that can get people seen quickly. And Houston Methodist here is responding to that. We know that our employees have been some of the hardest hit with mental health problems due to the pandemic. They're working incredibly hard. They are in very high stress jobs, and they're very devoted to their patients and their fellow employees. And we saw that they could not get the care that they needed. And so I am incredibly proud of how Houston Methodist has responded to this. We are the first healthcare system in the nation to offer comprehensive behavioral health treatment to every employee and dependent on our health plan, free of charge. We offer both in-person and virtual care, and we have some of the very best clinicians in Texas providing that free care to our employees. We have some group therapy starting soon. We're doing some outreach across our health system to try to reduce some of the stigma associated with getting care. But we now have the emotional health and well-being program that is available to everyone. This is considered an in-network program for our health plan, and it is given by the same clinicians that work in the complexity clinic. It is something I really can't say enough about how meaningful this work has been to me and to our fellow clinicians in behavioral health. Taking care of our own here at Houston Methodist has been one of the most satisfying things I've been able to do in my career. So, thank you. But that program is not large enough to meet everyone. What can we do to help meet the needs of all the people that are out there in our community and all the people that are here already at Houston Methodist getting care? And so what we've done is taken evidence and implemented what we call the collaborative care model. So we are embedding therapists in our clinics, in our primary care program, and hopefully we're going to be expanding to some of the specialty care clinics that will help patients address their psychological needs that are impacting their health and healthcare. So we're providing these therapists. This is covered now by most insurances. It's a little bit of in-person and a little bit of virtual care. It's the kind of thing where your primary care doctor, instead of making a referral and sending you off to hopefully find a provider somewhere, can say, I'd like you to see April. She's a therapist that works here with us, and April will collaborate with the patient, the primary care physician, and a psychiatrist who's in the background providing some supervision, recommendations about medicines, to try to help really kind of reach people before they're needing individual therapy in my clinic or to see a psychiatrist, to focus on getting care early and working on prevention. So we've done a really successful pilot project. We're expanding to additional primary care clinics. There are wonderful specialty clinics here that are interested in helping with this model. And we think it is probably the very best way we can reach as many people as possible in a way that is financially viable for our country. We also looked at the data that's been promoted. We looked at the disproportionate impact that COVID has had on women. And we decided as a hospital system that we wanted to focus a little bit more on women's mental health. And we recruited Dr. Jessica Rohr, whose main interest has been in women's mental health, and that includes women in general, but also in special phases of life, menopause, pregnancy, and the postpartum period. We're collaborating with OBGYN to provide specialized mental health care for women throughout our system. She just got here, so we're just starting, but we're really proud to have her here. And then finally, an important area for me is that we're going to continue to try to expand the continuum of care here in Houston. Traditionally, we've had inpatient psychiatric care for people acutely ill, and we've had outpatient care for people who are not suicidal. They don't always meet everyone's needs. There are intermediary areas like residential and independent living where people actually can spend the time getting a little extra care and supervision, where they can really go from safe to well. And we are working with David Lumpkins and others to try to look at how we can best implement some residential care here in Houston. Embarrassingly, are very few options for this type of care in Houston, Texas, or even the states around us. It's very hard to find. So research and education took a hit after COVID. We had a hard time getting patients to come in for studies. We had to move to virtual, and it was disruptive, although I think we adapted as well as we could. We are really positioning ourselves as a program who's willing to collaborate with anyone wanting to do good for Houston and our community. So we have our own Houston Methodist Psychology Fellows. We now have Baylor and UT residents. We have medical students from Baylor as well as Texas A&M, and we even have a collaboration with the University of Houston Clear Lake. Just this week, we were able to establish the first in the world fellowship in psychiatric microbiology. Many of you have heard us talk about the gut microbiome and the impact on mental illness. And want to talk for just a moment to give a brief update on that program. We have, before we had the primate brain, the mammalian brain, the reptilian brain, we had the enteric brain, the enteric nervous system that takes care of coordinating the motions of our intestines. There is a bidirectional flow of information from the enteric nervous system and the bacteria in our gut and our brain, and it influences stress, anxiety, mood, and behavior. And we are looking in our populations to find clues on how we might be able to manipulate the gut microbiome to improve people's health. Initial studies that we've done have shown that if you have a reduced amount of diversity in the gut microbiome, you have poorer mental health. Now, we wondered if that would actually link to suicidality, and it doesn't. But overall, if you have a less diverse microbiome, you have poorer mental health and poorer outcomes. We also have identified a bacteria that's now associated with depression. It's called Coprococcus, and it's been repeated now. After our study, it's been repeated in a Dutch and a Chinese population. So it's a very interesting finding that in 3 corners of the world, we find this particular bacteria with depression. And we are now starting some gut microbiome studies in our patients with psychosis and serious mental illness, and in particular our opioid-dependent population. In the press, there's a lot of information about psychedelics. It's kind of the sexy thing in mental health these days. And there are some promising studies out there now showing benefit of things like MDMA, which is ecstasy for PTSD. And that's actually MDMA combined with intensive therapy, not just MDMA. As well as the use of ketamine and even psilocybin for depression. The studies are actually very promising, and we hope to be involved in some of those here at Houston Methodist, and we are, those researchers are well known to us and are interested in collaborations. The other thing that's been in the news recently, and I will mention the author here, Nolan Williams, is a researcher at Stanford. Nolan was my medical student and my resident in neurology and psychiatry, and he was also my kid's karate instructor. Nolan has done a study looking at repetitive magnetic stimulation of the brain and depression. This is a treatment that was actually invented at the Medical University of South Carolina, where I trained. And we've known that magnetic stimulation can help with depression, but there's been little research done at what intensity and what dose of treatment is the best. Nolan just published a study showing that if you are really successful in targeting the right area of the brain, 10 minutes, 10 times a day for 5 days had an 80% remission rate for severe depression. This is not response. Medicines have a 30% response rate at 6 weeks. This is an 80% remission rate that was sustained actually over a month out after their treatments. So it's extremely promising, and we're actually hoping to work with Nolan here in a collaboration and use our own Houston Methodist invented rotating spinning magnet magnetic stimulation device. So we'll see how that goes. Hopefully an update about that in about 18 months. So I also just want to end with just reminders for everyone how to stay well. Stay connected to your friends and loved ones. Try to dose things. Do what you can. Don't try to take on everything. Try to be present in what you do. And mindfulness is a wonderful way to achieve that. Be open to experiences and accept what's out of your control. Most importantly, connect what's important to you and act in accordance with what your values are. Show people kindness and gratitude. It's actually one of the best medicines that we have, and it's free and it's without limit. And take care of yourself. Sleep, eat well, exercise, do all the things our moms know to tell us to do, and that will help you stay well and weather the storm. If you need care, if you're having trouble, here are some numbers that are available to you. And I'd like to highlight one. The Hope and Healing Center has established what's called a warm line. It's for people who maybe aren't imminently suicidal, but are really in need of someone to talk to. This is a free service that's staffed 5 to 8 p.m., 7 days a week. Hope and Healing Center is run by wonderful people, and they're really there to help, and they will help connect you to care. So thank you all for your attention and support. And Mark, I'm going to turn it over to you. And I'm supposed to say we're having a addiction and recovery presentation next month. It's going to be very interesting. Please join us.
Thank you, Dr. Weinstein. Wonderful presentation as always. I've got a couple questions for you. So I guess one of the fundamental things for me always, I'm a primary care physician, as you know, and if I think about the top 5 things I see and care for in my clinic, depression, anxiety certainly are way up there with hypertension and high cholesterol and a couple other things. But still, I think about, I'm going to give you an example. I think about a friend who gets a bad diagnosis of cancer, and most of them will share that. Not everybody. Some people obviously have different levels of privacy, but they'll mostly share it. Their whole world comes around them, embraces them, and helps them, and brings them meals, everything else. Yeah. And I think of people I know, patients in my practice or friends sometimes, and they have a severe psychiatric illness, severe depression, suicidal, maybe admitted, et cetera, et cetera. And there's still sort of a stigma, even though we are so much better than we used to be. And it seems to me those people would benefit probably even more than the cancer patient from every one of their loved ones coming and helping them and embracing them and caring for them. So how do we change that? And what do you do as a psychiatrist maybe to help bring their loved community, their faith community, everybody around them to help them?
I think, there's as a society what we need to do, and then what we can do as individuals. As a society, I think having people being willing to go out there and say, I've struggled with depression, I've struggled with anxiety, make it acceptable. Depression and anxiety affect people from all walks of life, no matter what their level of success is in life, no matter what their means are. All of us have vulnerability to mental illness. It's genetic. It's experiences in life, and when there's a perfect storm, depression can bring any one of us down. And just like cancer can, just like a stroke can, mental health has tremendous impact on the functioning of our mind and body. This is a medical problem that's no different. People being willing to go out there and say, that happened to me. That can make a difference. And then interpersonally, I think really with our patients, talking to them, offering to talk to their families about it, being able to say this is a normal reaction sometimes to a terrible experience. For instance, many of our patients have histories of trauma, and they have all sorts of different biological changes that happen from a trauma. And this is what happens to people. And say, it's tell people. And when you actually go one-on-one with people and talk to them and tell them, you'll find actually that people are really wanting to be outpouring of their warmth. People care. And if you give them opportunities, they will show you. And hiding it only serves to actually increase your suffering. Connection with others is healing. And when people hear that you're suffering, they actually generally forget about stigma, and they want to connect and say, well, how can I help you? And just really, I just encourage people to be honest and not hide how they're feeling, because that's something that we often see as a big strength, the stoic, strong person that can weather all the problems. Studies show that that's actually not healthy, and that those people pay a big price for that. They also feel chronically missed and misunderstood by others. Actually being able to show your emotion and allow people to see your vulnerability invites people in, creates stronger, healthier connections, and leads to better outcomes with medical and psychiatric illness.
That's a great answer. And so, what I've found is once people start talking, inevitably they figure out everybody else is just like them, just at a different degree. What over someone's lifetime, or the population's lifetime, what percentage of people will have, let's say, depression, anxiety, and then maybe mental illness in general?
So serious persistent mental illness affects 1% of the population. So things like schizophrenia are 1% of the population, bipolar disorder 1% of the population. Probably some people have estimates up to 5%. Depression and anxiety, you can see that we have, just from our statistics, up to a third of people are experiencing it right now. So over the course of
this moment.
Right this moment. So over the course of someone's lifetime, it is actually probable that they will experience some trouble with depression and anxiety. It is expected. It's actually the lucky person that doesn't ever experience, some type of mental illness.
So other than, joint aches and pains, infectious diseases, the flu or colds and things like that, which, pretty much everybody will have in their life. Can you name something else that kind of you would say that about? Hypertension affects a lot of people, but nowhere near that many. High cholesterol, nowhere near that many. Diabetes, nowhere near that many. Cancer, et cetera, et cetera.
I really can't.
So it's just that, unfortunately, it's that kind of little bit black box of the human mind that has been stigmatized through the centuries, particularly when we didn't understand things as well. So
absolutely.
So we have to change that. Well, that's really helpful. Okay, I have one last question, then we'll need to move on. But I was intrigued by your discussion about the magnetism. So, for people watching, right? For I don't know, decades at least, maybe probably more than a century, we've known electroconvulsive therapy works, right? Which is shock therapy, for a crass term, and still used in severe depression.
Sure.
Very effective, but it's sort of like a reboot, I guess, in my mind, right? But electromagnetism is connected. So is the theory a little bit the same thing, and is this just a much more targeted way of achieving some of those kinds of results?
So it's similar. Electroconvulsive therapy use electricity or magnets to cause a seizure. It's actually the seizure part that's therapeutic, and the seizure does something we know to reset things, to reboot things. What transcranial magnetic stimulation is doing, and in particular Nolan Williams' study that I referenced, is targeting a specific area of the brain to increase connectivity between areas of the brain, increase communication between really some of the logical brain and the emotional brain, and give people a little bit more sense of connection to their feelings and ability to use their thoughts to help them feel better. It really is actually enhancing the connection between areas of the brain with different skills. And it's
like cognitive behavioral therapy in a can.
Yeah, truly, brain stimulation and therapy do a lot of the same thing, and I think what we're gonna see is that a combined approach is going to be more effective for people, and it's very exciting.
That's really neat. I'll just say one other thing. That's actually a great potential future project, so I'm excited to see it, because we have this amazing, shower cap. We like to refer to it. It's a magnetic cap that can actually, direct magnetic field very specifically. And it started out looking at stroke, and it was a project that came through our Translational Research Initiative, so it's been funded by very generous people who've kind of helped seed fund that, and it actually has some licensing associated with it and other things. And then we began using it, and some people may have seen in the newspaper recently, saying, well, maybe this would work against glioblastoma, and looking at delivering magnetic field to brain tumors. And it's been pretty exciting very early, but exciting early stuff. And now you're saying it may work here. So this is a really potential transformative and also transformational, and also something that comes out of a really great program that we have in our academic institute and many generous donors. So, well, again, thank you, Dr. Weinstein. Very much appreciate you and that presentation. Dr. Weinstein will be here with us, and we'll may ask him a couple COVID questions as well later. So just fair game, or fair warning. So now I'm going to move to Dirk. Dirk is going to talk about COVID again, how to live with this in an endemic and maybe another surge phase, and specifically the Omicron. And then I'm going to come back and kind of put that in some context of our Houston market, about Houston Methodist, where things might go. So Dr. Sostman.
Great, thank you, Mark. And Ben, thank you for a really illuminating talk. That's just very difficult environment and great programs. So I'm going to talk initially about Omicron, which has been in the news, the latest viral variant, and then sort of recap some of the advice about living with COVID. So you've all read about the Omicron variant, I'm sure. What's different about it is that it has a huge number of mutations, about 50 or 55 mutations, 35 of which are in the S protein, which is the protein that it uses to dock with the cells, and also the protein that our antibodies and monoclonal antibodies target. There's a lot we don't know about this, and I'm trying to strike a balance here between telling you what we know, but I don't want you to feel that this is solid, firm information. I think this is undoubtedly going to change as we learn more. But what we know now, we think, is that compared to the Delta variant, which is basically 100% of COVID in America, it's more transmissible, a lot more transmissible. It probably causes a milder illness than Delta. And since it is so much more transmissible, I really hope that this fact stands up, because otherwise we are in big trouble. But it's looking now like it's a milder disease. Unfortunately, it seems that it is more prevalent in younger people, including children under 5 and infants. It clearly, we don't know the details yet, but it clearly has greater resistance to antibodies, so to vaccines and to the monoclonal antibody treatments. However, it is clear that vaccines continue to protect you from severe disease through cell-mediated immunity, because 80% of the antigenic determinants that our cell-mediated immunity recognizes in COVID are unchanged in the Omicron variant. So that's a critically important fact. So what does this mean for us? There's really nothing totally new about this, but basically your margin of safety and your margin for error is significantly reduced. I mean, there's a case in the literature already of someone who had a hotel room across the hall in the hotel from a traveler with Omicron who got it without ever contacting that person at all. So this is starting to look closer and closer to measles. So I think until we understand more, particularly about the severity, I would recommend that you be super diligent about the stuff that we've been advising you to do all along. And I think in a couple of weeks, things will be a lot clearer. So a couple of graphs here. On the left-hand side is the trajectory of each of the big surges. This is in South Africa, not in America. But in the red and the light blue and the darker blue, and you can see that there's kind of a slope of the curve that's pretty characteristic. The disease starts off slowly, and it accelerates, and then it plateaus, and then it starts to go away. The black line on the far left, labeled Omicron, is the rate of increase in Omicron. And you can see this goes straight up like a rocket ship. This is a totally different behavior than we've seen before. And once it gets established in Houston, and as you know, we've already seen our first cases, it's going to move rapidly. The panel on the right is in orange, the Omicron prevalence in different age groups, and in blue, the standard COVID. And you can see that in the older people, perhaps because they've already had it, I really don't know what the explanation for this is, Omicron is less prevalent. But once you get to the folks around 40 and below, it is much more prevalent. So antibodies and vaccines, a couple of bits of data here. Mark, I think, will show you another one. It's clear that Omicron is less sensitive to antibody neutralization. So the first line of defense against infection is significantly weakened with Omicron, but not totally obliterated. Left-hand graph shows in orange people who've had 2 doses of Pfizer. In green, 2 doses of Pfizer plus previous infection. So very similar to 2 doses of Pfizer plus a booster. And you can see that the more you're vaccinated, the better off you are. So go get a booster if you haven't already, because this is like 40 times more resistant to antibodies. On the right-hand panel, a Swedish study that indicates, well, maybe not 40 times worse. Maybe it's 5 times or 10 times worse, but it's still worse. And probably the data that I believe the most, I don't have a graph of, and that's a study done by the Pfizer company that showed that it's 25 times more resistant to their vaccine, but that with a booster that resistance is overcome. So again, get a booster. Here's a chart that I prepared, and this is not exact, but it's approximate. On the bottom horizontal axis is the R0, or the native transmissibility of the virus. On the vertical axis is the fold change in resistance to antibodies. You can see that Delta is pretty sensitive to the antibodies, but has an R0 close to 6. Which is about twice what the original variant did. And if you look for Omicron, it's way, way off the chart there, that big orange dot. That is both more resistant to antibody neutralization and more infectious. We don't know the exact numbers yet, so this chart is just kind of schematic, but directionally it's absolutely right. And your best bet is get a booster if you have not already. Severity. The anecdotal reports from South Africa are clear that they are seeing milder disease. People who are hospitalized with COVID, with Omicron, often are hospitalized for some other reason, and they've got an incidental positive COVID test. They're seeing many fewer patients requiring oxygen, and they're seeing shorter lengths of stay, like 3 days versus 8 days, than they had before with COVID. Another graph, which ultimate provenance is Johns Hopkins, shows a plot of the case frequency on the horizontal axis and the death rate on the vertical axis lagged about 12 days after the case rate. So, accounting for that lagging indicator of deaths. And you can see in those dark blue dots that there's a pretty, more or less a 1-to-1 correlation of this. It's a double logarithmic plot. So that's a kind of a rough indicator of the severity of the infection. A little harder to see, but I put a red circle around a couple of them. The lighter blue dots are cases of Omicron, and you can see that it's a totally different slope, and again, seems to indicate lower severity. So what do we do about this? Well, remember that three-legged stool. It sits on a platform of masks and hand hygiene and social distancing. And it has the three legs of vaccination, testing, and treatment. And great news, we've got all of these available to us now, and they are going to get better. And what we need to do is have everybody use them. So I'm going to go through this really fast because I think most folks have seen this before. COVID is transmitted in respiratory droplets and airborne vapors. Key thing that you should do is, in dangerous situations, use high-quality, well-fitting masks. And just follow a common-sense approach. You just on the left-hand side, just an illustration of what you're faced with when you're next to somebody who's coughing and sneezing, or even talking loud with COVID. And on the right-hand panel, this is not COVID specific. This is what happened to influenza last year. Look at these seasonal peaks every year, seasonal peaks, these big spikes of orange cases of influenza. 2020, 2021, it just disappeared. The common cold sort of disappeared. A lot of other respiratory viruses disappeared. That's kind of a side benefit of all this COVID stuff. Social distancing, with respect to Dr. Weinstein, who hates that term. It's physical distancing. Look at the seasonality of COVID. I'm going to play these videos, and the left-hand map is the temperatures. Blue is cold, orange is hot. And on the right-hand map, the red dots are going to show you the prevalence of COVID. So as it gets warm down in the south last year, you see those orange in Texas and Florida. You saw it popping up. Then as the Great Plains turn blue, the cold, you see the COVID spreading in the Great Plains and then just taking over America. Then you'll see as the temperature gets warmer in the Great Plains, it goes away. As it gets hotter in Houston and everybody's huddling inside with the air conditioning, you're going to see COVID popping back up. As Houston turns orange, COVID shows up again. So this is, I think, this is why you have to worry about being indoors, crowded together with a lot of other folks. If you change your air conditioning filters, I would use higher quality air conditioning filters. There are room air cleaners that have HEPA filters that you can use. And there are now available, really good quality masks. I mean, anybody can buy an N95 mask if they want to. And just, really, if you're going to have to live with this, you can't have, like a checklist every time you leave the house. But just take a common sense approach. Are you susceptible? I mean, if you're immune compromised, you got to be a whole lot more careful. If you've been vaccinated and boosted, you got a margin of safety. How prevalent is infection in your community? How likely is it that person at the next table in the restaurant is going to have COVID? And what kind of exposure are you going to get? 4 family members, who don't get out much, who've all been vaccinated, sitting around watching TV, you're pretty safe. Crammed into a restaurant with people talking loud over all the noise you get in restaurants, and kind of shouting when they see friends come in, that's kind of dangerous. And, I don't mean to be pejorative, but remember that unvaccinated people are a danger to you. So personally, I would try to avoid people who are not vaccinated. Not a lot of updates on vaccines. We know that the protection against infection wanes. The protection against severe disease appears to be more durable, but we don't know how much more durable. Boosters clearly restore your antibody levels and your protection from infection. And pretty similar to 2 doses of vaccine plus a prior infection. Is that boosting effect going to be more durable than the first 2 doses? We just don't know yet. What about prior infection? We get a lot of questions about this. Prior infection by itself is probably about 80% protective. The data, because these are not clinical trials, obviously we haven't done clinical trials where we infect people, so the data quality is lower than the vaccine trials, but there's a couple of good observational studies that say it's about 80% compared to the kind of 95% of the vaccines. Less effective in older people, definitely less effective if the initial infection was mild. But good news, it reinforces vaccination. 2 doses of vaccine in a person who has previously been infected appears to provide really, really good immunity. Can we tell who's protected by measuring antibodies? Probably not very accurately. We know that neutralizing antibody levels are the best correlate of protection, but we don't know how to apply this to individual people. We don't have good data. We don't understand the role of cell-mediated immunity because it's really hard to measure. And antibody levels change over time. If I gave you a number, an antibody titer of 1 to 450, you're good to go. Well, is that 2 weeks after you were vaccinated? Is it a month after you were vaccinated? Is it 6 months after you were vaccinated? We just don't have that kind of data. And of course, different viral variants have different sensitivity to antibody protection. And finally, most of the commercial labs do not report quantitative antibody values. So at the moment, there's really no test that you can recommend to really tell if you're protected. Outpatient treatments, the monoclonal antibodies are very likely going to take a huge hit with Omicron because they are so tailored to the spike protein of the older variants. But there is one that Glaxo makes called sotrovimab, which is a so-called pan-sarbecovirus or pan-coronavirus monoclonal antibody, originally isolated from a SARS patient, that seems to neutralize all the variants, including Omicron. Again, very early data. The COVID pills, mentioned these before, but so the updated data on the Merck molnupiravir not looking quite as good. Seems to be effective, but about a 30% reduction in progression to severe disease as compared to the preliminary data in a smaller population that suggested about 50%. But this has been approved for EUA in the UK and also now in America. The Pfizer drug, no real new data on this, but it looks probably a lot better and also probably a bit safer. Testing, this is something we have not talked about a lot in the past, and we here in America are way, way behind the rest of the world. Particularly if the environment starts getting dangerous. I really highly recommend that you go out and get a bunch of home tests. Those rapid antigen tests are pretty specific. Their sensitivity is not great, but that's okay for the home use because what you're really trying to see is, am I infectious? And if you're in an infectious phase, the chance of these tests being positive is actually pretty good. So I definitely recommend this. This is a way of protecting those around you and other people. What could happen next? I think we can continue to expect new variants. We don't know, are they going to be better, are they going to be worse, or are they just going to be different? We don't even know a lot about the different mechanisms, and I know we had a question about this, which I'll try to answer now. Somebody asked, how did Omicron happen? How did we all of a sudden get this monster with all these mutations that just showed up? One possibility, like some of the other variants, is chronic infection in an immunocompromised person. Just the prolonged dwell time in the body allowed the virus to just keep mutating and mutating and mutating. Another possibility is viral recombination, where large segments of viral genome are swapped. And one thought is that SARS-CoV-2 swapped genetic material with one of the common cold coronaviruses that tended to make it a little milder and a little bit more infectious. Another kind of interesting theory is called reverse zoonosis, where we know that SARS-CoV-2 originated in animals, probably bats, and jumped to humans. There's all this question about, was it a lab leak or not, but originally it started in bats anyway. What about, and we've seen that domestic animals can get it, tigers and lions in the zoo can get it, deer can get it. So it clearly jumps back into animals. So what if it jumped back into animals, adapted to an animal host, and then jumped back into humans? That's another possibility. So there are a lot of ways that these things can happen. Now, the good or bad news is that severity of infection, transmissibility, and immune escape are pretty much uncorrelated. And that's what we're really hoping is going to happen with Omicron, that it's more transmissible, more immune evading, but, please God, let it be more mild. Of course, the other thing, and I'll ask Dr. Weinstein to comment on this if we have time in the Q&A. There's still a lot of people, like 40% of people in America, have not gotten vaccinated. And, this is not an accident. It's not that they haven't heard about vaccines. But a lot of people are hesitant, and a lot of people have really drunk the Kool-Aid of these, these horrible, terrible people who are purposefully spewing misinformation in the news media and social media. These people, I believe, have been responsible for many thousands of deaths and should be held accountable. But why do people believe it? And if you have somebody in your friends or family who, have heard this stuff and are, they're really convinced by it, or they're bothered enough by it that they haven't gotten vaccinated, how can you help get them to understand, that this really is for their benefit and for the benefit of those around them? And then, of course, just to end on a happy note, say this facetiously, this is probably not our last rodeo. If you look at just coronaviruses, we've had, in the last 20 years, we've had SARS, we've had MERS, and we've had COVID. Does anybody really think that the next 20 years we're not going to have a new coronavirus? I don't think that's the way to bet. And by the way, while that's all been going on in the last 20 years, we've had Zika and a bunch of other, viral illnesses. So we at Houston Methodist are going to try to help the country get out ahead of this. We can't, prevent global travel, nor do we want to. We can't prevent development of wild environments. We can't prevent agricultural intensification. All these things are going to raise the potential for what the epidemiologists call disease X. This is the stuff that they make those apocalyptic movies about. So maybe at a future town hall, we can tell you about some of the programs that we're putting in place that we really are going to be doing our part. So sum up, the good news is that if we use the tools that we have now, and these tools are all going to get better, we can control this pandemic, and we can learn to live with it, and we can go on with life in a very healthy and economically sound way. Thank you.
Thank you, Dirk. Great presentation as always, and we'll have some dialogue and some questions in a little bit about that. I'm going to share with you some additional information about kind of the status for Houston Methodist, the status in our community, some thoughts about where we might go, and amplify some of Dirk's real key messages there. Really proud to say that the day before Thanksgiving, it couldn't have been better timed in terms of something we'd be thankful for. We hit our 1 millionth vaccine administered. I mean, if you think about the prodigious effort to do 1 million vaccines, the teams that did that, built that here. I'm in awe of what they really accomplished. Lots of fun facts. I mean, a couple million Band-Aids and other things like that utilized, as you can see. We're now about 23 million past that, or 23,000 rather, past that. When you look at that, about 120,000 of that now are boosters. And so we'll talk about boosters at length, because they are really the key message today. I think you heard that from Dr. Sostman. You're going to hear that from me at the end, but I'm going to preview that now, which is, if you haven't gotten your booster, now is the time, and not a week from now, 2 weeks from now, but tomorrow or Monday. I mean, you can do it. We've got the capacity. Go get your booster if you've not done that. But talking about kind of the status right now, this is our overall curve. You've seen this a gajillion times, but I'm going to zoom in on the right side of that curve. This is the right side of that curve going back to the end of October. So you see that right at the end of October was the tail off. We were still going down, and really since right about Halloween, we're in steady state. I mean, we actually have slightly come down again the last few days, which has been nice, but this is steady state. Put this in perspective, a really bad flu season, a good flu season, average flu season rather, we will have about 100 patients in the hospital system, across the hospitals. So this is bigger than the peak of that, and that peak lasts about a week or two at most, and then you're on either end of the curve of that, but this is an ongoing curve. In a bad flu season, what we had 4 years ago, it was about 200 patients. So this is very manageable. I mean, if this is the steady state, we're in good shape. We got it. We can be pretty much normal. And in fact, as you see societally right now, I mean, there's very little being done from a, social protection kind of standpoint right now, which is going to become an issue, obviously, and I'll talk about that with Omicron. But it's been obviously fine over this last period of time. But for Omicron, I'd be sitting here saying we are in good shape in Houston, Texas right now, with really no inklings of a big change, and let's seize the moment. And I think we have been seizing it, but unfortunately Omicron may be starting to change that. This is the IHME projections. On the bottom, you see the hospital resource use, and basically for months, they project something similar to what we saw. Now, these projections are pre-Omicron. I mean, they don't take into account a new variant coming in place. And so that, of course, is one of two key wildcards. But the other key kind of but in what I just said is that while we look really good, lots of the rest of the United States don't. And so you can see these hotspots, and this tracks obviously that seasonality curve that Dirk was showing, and we're seeing sort of that almost replication of that here this year. This is very regional, and so if you look at this graph, and the top is sort of the arc of the pandemic, the bottom is zoomed in for more recent times. What do you see going all the way back? You see 4 regions, and you see the Northeast was the first surge. Nobody else really had that bad a surge. Then summer of 20, it was the South, and it was even more concentrated than that, which is why it wasn't that steep in Houston. That was about as steep as it came, as we all know. And then this winter, it was kind of everywhere. Last winter, it was kind of everywhere. And then here we go again, and we had the South, and this time it was widely distributed in the South. That's that light blue line. We obviously felt that big time here. In fact, it was our biggest surge we had. And we've come down really nicely. The West, which actually had a not as big a surge, has come down less so. And then now you've got the Midwest and the Northeast basically surging, although, again, these are case numbers, not hospitalizations. Their hospitals are nowhere near as full as in previous surges, but as I'm on listservs and other communication with CEOs in many of these places, they're now kind of doing the things we were doing in July as they're prepping for possible, significant surges and figuring out the juggling of all of that. So, one big but is, don't forget, this is happening in other places in our country. It goes to show this has always been sort of a series of, localized epidemics. That is the pandemic, but it's not always been synchronous everywhere. And so, but for the next but that I'm going to say, we are in pretty good shape in Houston, Texas. One of the things I want to amplify again is that vaccinations are working, and they are working beautifully. This is Israel and UK data. And in the gray, you see the cases across their different surges. In the pink, you see the people who died across those surges. So clearly, in that first surge, we weren't testing. So the gray is just, way understated, I'm sure. But as we had tests available and you see the deaths that were occurring, they have not decoupled completely, but they are significantly down. This is because of, as you see, the 25, 50, and 75% of the population thresholds. This is because those countries did a very good job at vaccinating their populace and are preventing severe illness and death. This is United States data, very interesting data, and this goes over the last few months, so really kind of the time of Delta. And on the left, what you see is the top line is infections that happen in unvaccinated people. The bottom line is infections that happen in vaccinated people. And depending on the timing, right now, you see where it's come down to, there's a 5-fold difference. So you're 5 times as likely. There's a denominator to this, so this is per 100,000. So this is a population-based look. What you are seeing here very clearly over a long period of time now, about 5x, and it was as high as 7x at different times, more likely to be infected if you have not been vaccinated. But here's the real clincher on the right. While we still see breakthrough infections, right now you are 13 times more likely to die from COVID if you are unvaccinated as if you were vaccinated, and that's been as high as about 15x depending on the time. Obviously, lower rates overall because we're at a better time overall as a country than we were before. I mean, if I just don't know how to get to everybody because this is such a no-brainer to get vaccinated when you see these data here. And then one last thing I want to talk about, because of course there's still a lot of talk about mandates and everything else, and of course we led the way for healthcare institutions with a mandate, and all along I've said, we are unique. We have sick, vulnerable patients. Well, nursing homes are part of that healthcare environment. This is hot off the presses, New England Journal of Medicine yesterday. So this is as peer-reviewed gets and as prestigious a journal as it gets. So this is the real deal. And this looked basically at counties with a high prevalence of COVID. That's on the left. So a time during a county where you see lots and lots of COVID, and on the right, a time where COVID just, isn't that much. So it'd be like looking at Houston, for example, this summer, or looking at Houston now, as an example. In the kind of red grouping of, in the kind of red grouping on the left, what you see is a curve that's at the top box, the people who've been infected, the middle, and that's the residents. The middle one is the staff who work there who've gotten infected, and then the deaths that happened. The red grouping are low vaccinated institutions, in the kind of bottom quartile of those. The blue is the institutions that have high rates of staff vaccination. So what you see is a very significantly higher number of cases in the staff, a higher case in the residents who live there, and a higher number of people dying in those nursing homes if staff are less vaccinated. This is the best study I've seen that proves what we knew was the case, which is our sacred obligation is to keep the patients safe, and one of the ways of doing that is making sure that we do everything we can to prevent one of us from unknowingly, unwittingly, and obviously never wanting to give an infection to a resident or to a patient. Again, all healthcare facilities should be mandating vaccine. That is a no-brainer. It is our obligation to you, the public, as our patients. And unfortunately, that, again, is one of those politicized things, as we know. So, of course, the huge but in all of what I was saying about things are pretty good right now, we're kind of in steady state, it looks like it could stay that way, is now we have, this new variant kind of barreling down at us. So I want to review a little bit of the data and talk about what we know and what we don't know and what that might mean for us going forward. This thing has moved through the United States so far and the world very quickly, right? It was November 9th, 10th-ish that they first saw anything in South Africa. It was blowing up kind of over Thanksgiving weekend, which is when the world kind of became aware of this in a major way. And, it's already been reported in multiple places in the United States and, 50 or 60 countries already. So that is very rapid. As Dirk showed in the Gauteng province, now, for anybody who hadn't looked this up, the Gauteng province is the province around Johannesburg. So this is the population epicenter of South Africa. Obviously, there's some other major cities there, Cape Town and Durban and some others, but that's obviously their major city. So a big population epicenter. And what we see is the number of infections, the number of people diagnosed with Omicron shooting up right now compared to what they have seen in previous surges. If you zoom out a little bit and look at South Africa, you're seeing a South Africa-wide curve, largely driven in that region, but it is South Africa-wide that you're seeing that kind of growth. But part of that question, and Dirk touched on this, and it's going to be one of the fundamental questions for this, is what is that doing to hospitalizations and death? This is South Africa-wide. Now, you can plot this as a normal curve, or you can plot this on a log curve, which is a way that you really try to pick up exponential spread. And you have to do that latter to even see that, they're in the start of some exponential spread there, but at least nationwide, not nearly where they were, but probably the steepest slope they have seen on that so far. This is, and Dirk showed one of these pieces when you look at the Gauteng province, and what you see is on the left, we already kind of looked at a different way of displaying the same data. It is shooting up. Positivity rates are shooting up, and hospitalizations with patients positive with COVID are shooting up. Now, the good news in all of that is we're getting a lot of signal from them. It's anecdotal, reports now this morning, I'll give you one just hot off the press, that those tend to be milder cases. There's lower lengths of stay, less ventilator utilization, younger population. Now, South Africa is a young population to begin with. So, and in fact, the CEO of the largest hospital group across the Gauteng province this morning announced that they believe this is decoupling. And in fact, what he states is that a lot of the patients in hospital with this, as Dirk mentioned, are actually kind of incidental. In other words, you're testing everybody in a hospital environment and this thing's blowing up in the community. So everybody tests positive, but they're not necessarily there for it. That would be obviously a really, really good thing if that is the case, and that proves out to be the case. I mean, we have to put some protections in place for a patient who's here for something else who has COVID, but if you're not managing their COVID and they're not critically ill, that's a dramatically different scenario. But that's a big if right now. We just don't know. South Africa is a very different environment. It's a much younger country than we are. It is much less vaccinated than we are. They only have about a 30% one or more vaccination dose environment, and they have no boosters. Boosters have not been approved there. It's not to say some people might not have worked one out in their own hands, but really, really low percentage of people there who might be boosted. So you got to take everything with a grain of salt as we look at it. I will say as an aside, I don't have any slides, but the UK is doubling every 2 to 3 days right now in terms of the percentage of tests that they're coming back that are Omicron. So Omicron is clearly taking over in the UK as well. This is another curve that looks at kind of some of the things we'd worry about. So on the left, you see people who are positive with COVID, and you can see that uptick, and this is a log scale, so it's designed to kind of pick up more exponential spread. But if you were on a kind of non-log scale, it would look a little less scary. But you can see it's shooting up, as we said, right? In the middle, the ICU, it's shooting up, and in the middle, ventilators, it's shooting up. But at kind of a same time in the curve, those are much lower numbers of people. So some indication that it is less severe. Now here's the thing, and I'll talk about this again later. If this is so infectious that it infects, I'll make up a number, 20 times as many people, just to be extreme, and it's half as likely to go into an ICU, net, you're going to have way more people in ICU. And that's the concern I have with this, is that while good news, it looks like it may be milder, we could be in a scenario still where societally we could have dramatically difficult times at the hospital level. And the challenge we'll have is at an individual person basis, the risk will be lower than it's ever been during a surge. But at a population basis, we're still going to have all the negative dynamics, people dying, people in hospitals, crowding out of people with other health issues. So that, if you think we've seen challenging societal conversations and decision making, just wait until we have that kind of a scenario potentially. So for me, there's kind of 4 key questions. There's others, but these are the 4 key ones we're trying to answer as quickly as possible. And I will say, I mean, it's a kind of the world we live in today. I mean, we're now getting a lot of our information literally from some very reputable people who are tweeting information from South Africa. I mean, it is even more rapid than preprint. So everything we're talking about, take with some grain of salt. It's not peer reviewed. It's not been challenged, by the medical establishment and really gone through the things it needs to go through. But of course, we're in a fast moving situation, so we're using the information we can get. So is it more infectious? Very high probability. I mean, I think the data is pretty clear. And Dirk showed a lot of that. I've shown some of the trends, that this is going to be way more infectious. So will this spread and will this kind of take things over? Yes, and we'll talk about that in a second. This is allowed and lots of stuff, but this is South Africa. Now remember, South Africa has had more variants than we have kind of all along. They had that, the one beta variant that everybody was worried about that just never really got out of there because Delta outcompeted it. So this is kind of the proportion of tests per variant over time. But what I'll call your attention to is the purple line. That is when the Delta virus took over. You can see it happened over a course of months that it actually took over and became essentially, most of what was there, not all, in South Africa. Here it is 99.9%. And what you see in red is Omicron. And in a very, very, very short period of time, the proportion of tests, again, this is not number of tests, this is what percentage are each kind, has essentially taken over. We've not seen this before. I mean, that clearly is an indication of infectiousness as we go forward. It is here in Houston. We all knew it was. We know it's probably everywhere already. The first thing we saw was about a week ago or so, or a little before the weekend, I think it was, we saw one individual reported by the county. The city has been running wastewater analyses all through. They work with Rice, they work with Baylor on that. They found 8 out of 39 of the wastewater treatment plants had Omicron. So you can bet there's a whole bunch of people with Omicron. And we have been literally putting, as we always do, but now on an accelerated basis, every sample that tests positive on our sequencer. It takes about 2.5 days to actually do the sequencing. They batch it. So Monday, Wednesday, Friday, we run these batches. So last Fridays that ran, we got it back like Sunday night, 0. Mondays we ran, and that's a couple days in arrears. So some people who were diagnosed end of last week, as you may have seen in the press, out of 150 that were sampled or sequenced, which is everybody we had up to Monday, 8, and actually this morning we know it's 9. They corrected one thing, so 9 patients. So that's already over 5%. We'll see what happens with the ones that got loaded yesterday. We'll have them back tomorrow, but we're all betting they're going to be up, unfortunately, and very quickly. This is what happened with Delta. So on April 15th, we caught our first case of Delta, and it was the first case, as you may remember, reported in the city of Houston. We still are really one of the most prodigious sequencing efforts anywhere on the planet. We have sequenced well over 60,000 now, and essentially everybody who comes through. And it took about 75 days to get to where most cases were Delta. And if you think about that timing, that took us to about July 1st, which is where we were seeing an uptick, and about July 15th is when we hit sort of that logarithmic kind of growth or exponential spread for COVID. So about a 75 to 90 day period. But the infectiousness was way lower. So we are expecting to see this curve be much steeper, maybe not as steep as South Africa, we don't know, but much steeper. So when we speculate, and let me be clear, this is speculation, we're thinking 6 weeks, not 3 months. Could be shorter, could be longer, but as a guess, and we'll know a lot more obviously as we can model after a few more runs and see the trend line. But we do expect that we may be seeing by mid-January, early February, mid-February, somewhere in that time frame, a time frame where everything in Houston is the Omicron variant. So then the question is, what does that drive for our community? So second key question, and Dirk talked about this, is it, and I've talked about it already, is it more or less severe? I personally think we still have to put this in the unknown category. I think there's very good suggestion that it is less severe. I've shown you some of that data. Dirk has shown you some of the data, but we're talking pretty much one country's data in a very different environment than ours for the reasons I explained. So I think we have to, not become complacent and not assume this. And again, I want to very importantly state that, and Dirk used to show some slides like this of potential death, and he would show that more infectiousness actually ended up with more death than more severity because of the numbers of people. And the thing I'm worried about, again, we don't know, it may not pan out, but we have to prepare for it, and we societally should prepare for it, is whether this goes up so fast that it just creates so much illness, and even at a lower rate of severity, the law of numbers catches up with you, and you have more people in the hospital, more people getting sick, more people dying, and we just don't know that yet. This is another look at some of the data I've already shown you. This is not a log scale here, but this just shows a proportion of patients. So what percentage of patients currently in South Africa are requiring higher level of care? Are they in ICU? Are they on a ventilator? And you can see it's consistently far lower. So as long as it doesn't overwhelm us by sheer numbers, and this holds true, and it's not just that it's all young people first and later it's the old people and some other dynamics that happen, this is potentially really good news. Okay, so will vaccinations work against Omicron? I'm going to go into another set of data and a little more detail on one other study than Dirk did. I would put this as probable, with the asterisk being with a booster. Without a booster, from protection against illness, I think the early data suggests you're going to just see complete breakthrough. Now, protection against severe illness and death, because of what Dirk talked about with, he didn't talk about, but memory B cells, which make more antibody in response when they see it, and then the whole T cell mediated immunity, we still believe that most likely even 2 vaccines will significantly work against severe disease, but we do not know that yet. We can't know that yet. This is one of the studies. Dirk actually showed a blow up of the graph on the left. Small study in South Africa where they basically, simple terms, right, in a test tube, they're doing a mixing study of the virus versus some people's essentially blood product that they've drawn from people previously, right? And one group in the green are people who got 2 doses of Pfizer and have had a previous infection, which probably, based on a lot of other data, is a little bit like having a booster, probably, right? In the reddish is people who've just had 2 doses of Pfizer. On the left, you see the virus we had back in summer of 2020. So this is pre-even Delta, and how well essentially you could neutralize that virus with those people's blood samples. And on the right, you see what happens with Omicron. It's down dramatically in both cases, but it's at a much higher level for people who had that infection also. So there's at least some suggestion that a booster may actually get you to those kinds of levels. And if you look at those levels, they're not inconsistent with the original levels people had that clearly were protective. Pfizer just announced a couple data points. They show about a 25-fold decrease in antibody levels, but then basically are able to state that you can reverse a lot of that by getting a booster in their original data. And so very suggestive that a booster will up your antibody levels. They announced, others have announced, they all are developing Omicron-specific boosters. The reality is we don't know yet if that will be needed, and quite frankly, the reality is the whole machinery and process of creating vaccine, distributing vaccine, et cetera, is flowing right now, right? For normal vaccine, to get that up and running and going, even if it gets approved quickly, is months away. So don't wait for that. Even if it occurs, get boosted now, get your antibody levels up. The final one I want to show is one Dirk didn't show, and this is a complicated graph, so I'm going to walk you through it a little bit. But this is data coming actually done by some scientists in Frankfurt. Okay, so look at graph A with me. And what you see in each of these areas, you see the kind of gray data and you see the red data. So the gray data is against Delta. The red data is against Omicron. And what this is neutralization. So again, in simple terms, again, you take kind of these blood samples you've got stored from people in different categories, and you mix them with the virus, and then you see whether the virus gets neutralized or not. And you can see the individual samples are all the different dots. So what you see is against Delta in that first column, these are people who have had 2 doses of Pfizer. That's the 2 and everything else next to it. You see the little subscript there that says 6 months. So this is 6 months after people have had a 2-dose series. And what you basically see is everybody they measured has really, really low neutralization against Omicron if they're 6 months out. So we can expect you're probably going to see significant breakthrough, because this is kind of the antibody that's there and present. Now remember, this is not your body's ability to remember the virus and see the virus, and once it hits, start manufacturing more antibodies, because this is just a blood sample. This is not the body's ability to mount a T-cell response. This is just what's sitting there in the blood they sample. In the second set, what you see is people who have had 2 doses of Pfizer and a booster of Pfizer measured about 2 weeks after the booster, so really fresh boosting. And in both cases, you bump up the antibody response, and what you see is Omicron's not as good. But for many of the samples you see there, the Omicron's at least as good as it was against Delta before, so you can kind of reestablish the position people were in recently. In the third category, you see that 3 months out. So you get boosted and then wait. And again, you see the sort of present in your blood antibodies go down. That's kind of normal against anything we do. So it may not be quite right there to stop the acute infection, but your body's ability to mount a subsequent response. And then finally, on the right, you see actually 2 doses of Pfizer and an infection. And so as we've said very consistently for a long time, we believe having infections sort of like having 1 dose of vaccine. Personally, if I had an infection, I would still get both doses of vaccine, and based on the timing, I would eventually get a booster, period. Not everybody's going to want that, and certainly you can know that if you've had infection, it's probably like having a dose, but it's not like having 2 doses or 3 doses, and that's a very important point. They go through some similar stuff with a couple of the other vaccines, but they're kind of directionally the same, particularly with Moderna. The other thing I want to show, though, on the bottom right, that is a graph of then the neutralization that happens with the Regeneron monoclonal antibody, which is the widely available, everybody uses, that's pretty much what we use. And effectively, it looks like, based on this and some other things, it's probably close to useless when it comes to Omicron versus Delta. And that's disappointing, obviously. We would much prefer to have that, but I'll give you some hope around that in a second. So vaccinations will definitely boost those levels, and so boosters will. So we are strongly urging people to get boosted. So then the question is, okay, so if you get COVID, we have an array of treatments we use. Are they going to work? And of course, I'm not talking randomized clinical trials here. I'm talking either theory or some early trials that have been looked at. And so take all of this with a grain of salt that, data may move. But I would say this is a mixed question. So actually a nice article in the lay press on the left, I could send you to. The references could be there. You can Google the name. But it went through sort of the main things we're using out there, not the main things that are targeted, obviously not steroids and other things which are really more broad and will work either way because they're really about the body's response. But what you see, and Dirk talked about this a little bit, on the monoclonal antibody front, these are the approved monoclonal antibodies. So the Regeneron, which is the big one being used, Eli Lilly, most likely, Regeneron, I think almost certainly, Eli Lilly, most probably, they're not going to be very effective. GSK has one that, because it's designed differently, but it's not widely available right now. We've not gotten any yet. We have it on order and we're trying to get it, but just haven't been given any yet. It does look to be effective against Omicron. So we may be in a period of time here where we're really having to try to sort out at an individual patient, are they Omicron, are they Delta, for at least a few weeks here, and trying to figure out will they benefit from monoclonal. But right now, because it's mostly Delta, if you get sick, get Regeneron. And then obviously in the future, we will be trying to get that GSK. Remdesivir, if you look in the middle box, has been used for now, a year and a half as an antiviral used in the inpatient setting. Every reason to believe, and the manufacturer has stated so as well, that it should continue to be effective against Omicron. Dirk talked about the COVID pills, and I'm going to talk some more about those in a second. The one that's approved is Molnupiravir from Merck. It was approved a couple weeks ago now. It was approved about 6 weeks ago in the UK. When the final results came out, it wasn't as good as we hoped with the earlier results, but it still has some meaningful activity. Everything suggests that it's going to work with this. It's really not about binding the virus, but really about viral replication in the cell, which there doesn't seem to be a mutation that's changing that. There's a couple things out there that are not yet approved. Another monoclonal antibody called Adagio that probably is more like the GSK product. We don't know that yet, but they are stating they believe so. Again, it's based on the types of antibodies that it uses and what they target. And then I think a lot of hope around Paxlovid. This is the Pfizer drug. They actually just yesterday said they are literally in days submitting to the FDA. So I'm hopeful we'll have this in January, maybe before, at least some availability before this big surge, potential surge, happens. And so a mixed picture here. The two I want to focus a little bit more on are Molnupiravir and Paxlovid. We've been talking about these being potential game changers. Now, I will say Molnupiravir has been a little more disappointing. It's still good, but nowhere near as good in the final trial, so it isn't a game changer. It may be a game, alterer. It's a tool. Pfizer still could be much more of a game changer if those results hold up. Their CEO in those comments in that release said they believe, I don't think they have their final data, but they believe that efficacy data is going to hold up. We will probably see those data in the near future. So I did a little math just to show you what kind of effect could these have. So Surge 4 was for us was this summer. So we took all the patients we admitted with COVID from July 1st to September 21st. So there's still a tail on both sides of that, especially the second side, but gives you an idea. About 6,500 admissions to our hospitals. If you could give Molnupiravir to every human being who was diagnosed with COVID, which of course isn't going to happen, and you got results like we saw in the trial, you would cut the number of people admitted to our hospitals by 2,400, which of course is a pretty dramatic but not earth-changing impact. And then if you get kind of half or a quarter, you can kind of see what it would do. So it'll be helpful on the admission side potentially, but it's not going to be game-changing on the admission side. They had one death ultimately in the treatment arm, the bigger trial. Earlier it was 0. They had 9 deaths in the placebo arm. So if those hold up in a bigger population, that's a pretty dramatic death difference. So you can see if you could get this to everybody, you could prevent a whole lot of death. But again, you're not going to get this to everybody, logistically or practically, or people aren't all going to take it or want it. And then you can see kind of the in-between. I did similar analysis based on the early data of Paxlovid, and again, haven't seen final data, this may shift, et cetera, et cetera. This is much more of a game changer, right? If you could get it to everybody, you can drive out 89% of admissions. So even if you got it to a small proportion of people, you could really change that. And they had 0 deaths. So the math comes out, if you give it to everybody, you have 0 deaths. That's going to not hold up, obviously. Nothing's going to be 100% effective like that. But still, if it's anywhere near that effective, you could have pretty dramatic impact. So we're hoping and praying this gets approved, that the data hold up, and that we can get enough out into the community that it may be there for Omicron. Now again, we think it'll work with Omicron. We don't understand the severity of Omicron, so there's a lot of unknowns as we look at that. So the last thing I want to talk about is, are we societally ready? Are we doing everything we should be doing to weather another surge? One challenge we have, no question, is we are wide open right now, and it's understandable. And, honestly, this has been that seize the moment kind of period of time. I said that last month. What we've not done a good job of is when things change, saying, oh, we got to go back. We know what works. Let's get this in a box quicker. And we're not, I have no reason to believe we're going to do any better with that. So I'm not even going to go through those things, although we're going to need to do them. What I want to talk about then are a couple of the other things out there. Dirk talked about this a little bit. We, compared to many countries, the UK gives free tests at a certain amount, per time period to every citizen. We've not used rapid tests adequately. I would urge you at this point, they're pretty readily available. You can get a 2-pack online from Walgreens, and it's going to cost you about $13, $14, $15 a test. You can go to Sam's and you can probably cut that by about a third and bulk up on them. Use these. If you have at-risk people and you're about to do a holiday party, just swab everybody. You got 10 people there, it'll cost you $100, $150, and you will have a much safer environment. If you have any degree of any symptom, especially now as Omicron's getting here and it's going to be so wildly infectious, have these around and just swab yourself real quickly. I think this is a key strategy we've underutilized in our country, and I would encourage you to do that. Then I want to talk quickly about vaccines. I've said this before, we're horrible. This is really embarrassing that the United States is where we are as a country. We just crossed the 60% threshold, like literally in the last day. We've missed so much opportunity to protect people. You saw the 13 times less death risk. Think of the vulnerable people that are there as a result of that. And this shows kind of some of the continuing missed opportunity. The UK is on the left. And what you see is people who in light blue have only gotten a first dose. In dark blue, they've gotten what we would consider fully vaccinated still based on CDC definitions. And in red, the booster dose. US-wide, 15% of the population has gotten a booster. About 1 in 4 people who have gotten vaccinated have gotten a booster. The UK, about 36% of their population has already gotten a booster. But if you look at the vulnerable, you look at those older age groups, they are now 80% of 70 and up. 80% have been boosted. We're in the 40s. So we have a whole huge array of vulnerable people unboosted at a point where we're just showing you the data as best as we have that says get a booster now. So if you haven't done it, make your appointment tomorrow, over the weekend at a pharmacy, Monday, whatever. Go get that next booster shot now. And then here's another concerning piece about our readiness. So if you ask people, are you, as we authorize these FDA pills, so molnupiravir is now EUA authorized, we hope that Paxlovid will be as well. Really impressive pills, especially Paxlovid. Are you going to take this? Well, the good news is about 70-something% say yes overall. But if you actually ask and delve down, if people are vaccinated, 90% or so, 89% say, yes, I'll get it. And if they're unvaccinated, more than half say they won't get it. So the very people who are most likely to get sick, most likely to be sicker, et cetera, are saying they won't get this. And so unfortunately, somehow these are ending up in the category of vaccines so far, not the category of, some of the therapies that don't work that are talked about there. Now, of course, this is a theoretical question. People act a little differently once they are sick, but we really, if these pan out to be the way they are, especially Paxlovid, need to make sure we are using them. So I know it feels like we're playing Whack-A-Variant. We are, and as Dirk said, I think we will continue to do so. We have all the tools at our disposal. We know how to do this. If you walk away with one message from us today, it's if you've not been boosted, get boosted. Get boosted now, don't wait. Get boosted now. Create for yourself a much safer holiday, because we've got Omicron here. It's going to spread fast, and it's here literally over 2 weeks before the holidays, in the period of time when everybody's gathering, and so we're going to see that be an exacerbant on that. With that, I'm going to close. We're going to take a few questions. I want to wish everybody, obviously, a very happy holiday season, and of course, as we see in the cartoon here, we know some of the right things to do, and it's time to start really kicking some of those back in, particularly during this time of uncertainty when we just don't fully understand what we're about to potentially face. Thank you very much, and we'll be happy to take any more questions that come through, and I'm going to take us to a series now of Q&A, and thank you for being with us. Okay, Dirk, well, I'm going to pepper you because I've been talking for a while with a few of these. I think you can give us a quick answer, but it's just so fascinating. How did this come about? I mean, this is, it was like that. All of a sudden, we've got this Omicron here, and it is, majorly mutated compared to anything we've seen before.
Yeah. Well, and first of all, let me compliment you on your math skills. I had no idea. As Mark said, this sort of popped up out of nowhere with a whole lot of changes. So it's been brewing somewhere. It's either been brewing in an immune-compromised human being where, the virus could be alive in their body and replicating for literally months and just gradually acquiring mutations, and then at some point it jumps and gets transmitted to another person, and because it's so infectious, it just kind of explodes. As I said, the other possibility is that there's some other reservoir. And the really interesting thing about this coronavirus has been the breadth of infectiousness. I mean, house cats, dogs, white-tailed deer throughout the Midwest in the woods, lions and tigers in the zoo, rhinos, hippopotamuses. And so the idea that this jumped back into animals, adapted itself to the animal host, and then jumped back from the animals to the humans is kind of an appealing theory. And it's also kind of a scary theory, because if you think about, if this is going back and forth between animals and humans, we're never getting rid of it. I mean, we kind of knew already that we're never getting rid of this, but the potential for it to evolve, in these kind of step change ways is pretty scary.
So let me ask you a follow-on question to that. I mean, you mentioned there's sort of not necessarily correlation between infectiousness, severity, susceptibility, but viruses have to replicate. Killing people is actually bad business for a virus at the end of the day. I mean, if it's 100% lethal, everybody will die and it can't move to the next host. If you really take it to the extreme. I mean, is there a possibility that the fact that we're potentially seeing a milder virus that is so infectious that it kind of, as Delta seemed to do for a while, that it might just hold all these other things at bay? Is that possible?
Sure, it is possible. It's not quite as black and white because, as you said, the virus's sole job in life is to reproduce, and if it is able to transmit before it kills the host, it's fine for, it has no problem killing the host. And so if you're infectious when you're asymptomatic and then it kills you, that's just as good as if it were milder. It's really how long are you infectious and how mobile are you when you're infectious?
So it's really almost a human behavioral question, right? Because if it kills that high a proportion, behaviors change dramatically, right? If this was Ebola, everybody'd be sitting in their house, never leaving.
Yeah, exactly. One of my doctor friends said to me, again facetiously, if only COVID was a little more serious, we wouldn't be facing the problem.
Well, SARS and MERS both were serious enough you could box around it and pretty quickly identify everybody was sick. You didn't have asymptomatic spread, and once you got it, you were pretty terrified because you had you were double-digit mortality rates.
You were sick as hell, fixing to die, and so there is definitely a behavioral component.
Okay, so we're talking behavioral now. You alluded to asking Dr. Weinstein some behavioral questions, so we're going to put you on the spot, Dr. Weinstein, since we have you here today.
So I think a lot of folks. Many of us know people or have friends who know people, and we get asked, and I bet a lot of people who are watching have a friend or family or who say, I know I'm supposed to get vaccinated, but I'm really worried about all this stuff I've heard about fertility, or how do you talk to people who are reasonable, intelligent people, as many of these people are, who've just gotten hooked on some piece of misinformation? What's the psychology of them? Why can't they get over it? And when you face them with true facts, and what are good ways to help people get there so that they can do the right thing and get vaccinated?
That's a very complicated question, and there's a lot of reason, I think, why some people have become so afraid of the virus. I think we are a vaccine. I think that we're up against a propaganda machine. And if we were constantly bombarded with information that was incorrect by people we trust, you and I might believe the wrong thing as well. And I struggle personally with the idea that all these people out there who should get vaccinated that haven't. I struggle with the idea of where is our civic responsibility and where is our love your neighbor, which has served America and the world so well. And I come to the conclusion that that's not gone. That these are still good people out there, even though some of them present as quite angry and upset. I really liken it to dealing with a delusional patient. And when you're dealing with a delusional patient, facts stop mattering. And the only way you can reach them is to be calm, kind, consistent, and say, yes, but I'm worried about your health. I'm worried about your life. Let's not argue facts that are believed and are not convertible. That's if you're dealing with someone who believes that aliens are controlling their behavior, I'm not going to convince them that that's not true. What I might be able to convince them of is that I personally am concerned about them. That, so if you have a friend or family member or loved one who is in that group, I think continue with I'm worried about you, I'm concerned about you, I want you to be okay. I've had this vaccine and I'm fine. You can say, just from a personal experience, I'm okay. Everybody, I know all these people have been vaccinated and they're fine, But if you fight with the statistics and facts, I think those are lost on them. just like the delusional patient. And honestly, I think we're stuck in this kind of spot until the people who are giving the propaganda are held accountable. I mean, we're not allowed to yell fire in a movie theater. Why are these people being able to go to a movie theater on fire and tell people it's not on fire? You know, that's something that I really wonder. Like, where is our holding accountable people who are harming people?
Thank you. That's really great words and great advice of how to compassionately work with family members, loved ones, colleagues, others to try to move them if at all possible, because in doing so you're really protecting them and you're protecting you and your family and others as well. Okay, I'm going to move to the next question, and it's really a series of questions, and it's really around natural immunity and kind of embedded in this sometimes, kind of to some of the anti-vaccine movement is well, we don't need vaccine because we should have all just gotten infected, or we should get infected. And unfortunately, it's get mixed up in that, because as we've tried to show today, and we've talked about many other times, infection does create some immunity. We think vaccines are more standardized, more well studied, and probably more durable and effective, but that does not say that natural immunity isn't important. And so one of the advantages we have in Houston versus some parts of the country, honestly, I'm sorry we have it because a lot of people died to get there, is that we have a lot of people who chose not to get vaccinated, but they've been infected. And so they're walking around with some degree of immunity, and it will probably help protect them from severe illness. But every study we look at really continues to reinforce this idea, and really the science that says it's probably about the same as having had a dose. You got exposed to the virus, your body mounted antibodies. You got exposed to a vaccine, your body mounted antibodies. You got exposed to the vaccine a second time, your body then mounted antibodies, but it reinforces that first one, and a booster probably seals the deal. I mean, personally, I believe when all the dust settles, we probably had the first and second doses a little close together, probably. And that was the best people knew back then, and there was a hurry to get everybody protected. And that, maybe now with that third dose, we're getting more durable, certainly durable kind of T cell and durable memory B cell immunity and things like that. But that's kind of my take. And so I told you my personal belief. If I had the infection, and again, that's very individualized in terms of timing, but I would probably get all 3 doses still, because I'd be like, let me get the best protection I can. But I most certainly would say get 2 doses so that you basically are the equivalent of being boosted. Dirk, you got anything to add on that one?
Well, first of all, the issue of, why doesn't the medical community acknowledge this? And I think maybe we've done a poor job of communicating. I think the reason that doctors don't talk about this a lot is the things that you mentioned. We don't have as good data about natural immunity as we have about vaccines. It certainly doesn't seem to be better. It's not standardized. There's no real good way to give it. I mean, I don't think anybody except the real whack jobs are suggesting that the entire country should have just gotten, sick, because you would be talking about another 2 or 3 million dead people. But if you have gotten infected, and very importantly, we don't have good data about people who get infected after they've had 2 doses of vaccine, so the breakthrough infections. But we know if you've been infected and then you get vaccinated, your immunity is really, really good. But to your point, why not get a booster? There is absolutely no indication whatsoever that getting a 4th dose or a booster after you've had infection and 2 doses is in any way harmful to you. So why not just go ahead and get it and be safe?
Okay, well, thank you, Dirk. Well, I've got a question for you now. I think it's a quick answer, but people are asking the question. Okay, so, and we both talked about rapid testing. Do they work against the Omicron variant?
Absolutely.
So
They're
pretty
effective
straightforward.
now.
Yeah. So good news is, thank goodness, we didn't end up with a variant that basically eludes our ability to test quickly. Obviously, we could fix that very fast on the PCR. I mean, we can test for just about anything on PCR, but from those rapid tests, you'd basically have a bunch of worthless boxes of tests if that had happened. So thankfully they work, and as I said, pretty widely available now. So, okay, so here's some, detailed questions, kind of a little amplifying on that native immunity, but some people asking some specific questions about themselves, and they may have had a breakthrough or they may have had a monoclonal antibody. Talk about those questions there. So.
Okay, sure. So the first one, had both Pfizer shots, then had a breakthrough case that was mild. So first off, mild infection probably doesn't result in as strong immunity as, God bless you, you only had a mild case, but probably doesn't challenge your immune system the way a more severe infection would. So I don't think you can count on the native immunity there, and personally I would get the booster shot. And again, what's the downside? Okay. You get a sore arm, well, are you a pitcher for the Astros? Are you going to feel punky for a day? Take some Tylenol.
And plan their timing.
Yeah, exactly. Do it on a Friday afternoon.
Thank you. Okay, so here's a really interesting question. Some people are starting to say, they authorized boosters for some people at least in early August. There were a number of people taking it out of their own hands before that because other countries, Israel very notably, led the way on boosters. You remember us expressing some frustrations that it took us as a country so long with the data we were seeing at that point, and of course during a surge here in Houston. So for some people it's been 4+ months since their booster. Should they be thinking about an off-label fourth dose? Now, the reality is people can go to a site and probably just do that themselves, but the legitimate way to do that is physicians can prescribe Pfizer off-label because it's fully FDA approved. So a physician could choose to write an individual a fourth dose, a fifth dose, a sixth dose if they wanted to, and thought that was the right thing to do for their patients. So what are your thoughts around this?
Well, you got the issue of being protected now ahead of what could be a very major surge. You've got the issue of, if there's a tailored vaccine available in March, should I wait for that instead of getting a booster now? We don't know of any harm in getting a fourth dose or a fifth dose. In fact, some of the things like the myocarditis seem to peak at the second dose and go down on the third dose. So I would say, what's your risk? If you're going to do, if you have business and you have to fly to, Hong Kong in the next couple of weeks, I would absolutely get a fourth dose, personally. If you're a healthy person, not in a risk group, maybe not, not my age, then again, if somebody my age is going to go to a big family holiday gathering where people are going to come from all over the country, I'd probably strongly consider getting a fourth dose.
And it's the kind of thing you can talk about with your physician. And certainly if you're immunocompromised, many of those people are getting a third dose, not a booster, just even to get them. But if you're immunocompromised, you're about to undergo cancer therapy, other things. Again, these are not CDC recommendations now, but at least be having that. I mean, if you're immunocompromised, you've got a physician relationship, have that conversation with your physician. You may choose that it makes sense to kind of shore things up before a lot hits.
I mean, just to be clear, all the stuff we talk about is general here. This is not medical advice for a specific person. Talk to your doctor.
Thank you. Okay. How transparent is reporting of negative issues resulting from the vaccines? Are we still requiring them? Very transparent. We report any significant issues that happen with our vaccine. There's an organized process for that nationally. As you have probably seen, that's a kind of a bucket of reports from really any source. So the challenge the CDC has, the FDA has, the scientists and physicians have is then how do you interpret the data? Because literally everything gets dumped into, if anything, there's been over-reporting of a lot of issues, and there's even some speculation that there's been some, unfortunately, some of the really kind of out there anti-vaccine movement reporting that. What I can tell you is we have seen dramatic levels of safety of these vaccines. I mean, we really have. We have seen vanishingly small numbers of any of the major side effects. We've now done 1,020,something thousand vaccines. In terms of our employees, this has been required. Thankfully, we finished this, believe it or not, now 6 months and 2 days ago, which is kind of amazing already. We've really not had any major bumps or issues as we hire new people. It's an expectation they get vaccinated. We are kind of doing a call to action with our employees that if they've not gotten boosted, go get boosted. In fact, this content from today is going to be part of that call to action that will go out later today, and we will continue driving that forward to protect them and to protect you as patients.
Yeah, I know time's getting short, but I think it's really important for people to realize that the databases where they report, issues after people have been vaccinated intentionally are set up to suck in a lot of data that may or may not be related to the vaccines, and that's how they found that 1 in a million older males were getting Guillain-Barré from the vaccine or whatever. And you get these reports from the anti-vaxxers, like 16,000 people who got the vaccines died last week. Well, how many people who didn't get the vaccines died last week? Well, 20,000, but they don't tell you that 20,000. And so they're really misusing those reporting systems. Those reporting systems are incredibly transparent. Anybody who wants to can sign on to the FDA or the CDC websites and look at the data. But you got to understand what the data actually means.
Yeah, that's a great point. And I mean, I don't think there's certainly never been a more studied drug or vaccine before approval actually happened, and more utilized. Really we have hundreds of millions of expertise just here in the United States alone. So this is an interesting question. It's well timed because there's hot news off the press, which is there an estimate for some of the monoclonals being used as preventative therapy for people who are immunocompromised? Talk a little bit about the data that's been out there. Of course, this is pre-Omicron, and any authorizations that are happening with that.
Sure. So obviously, some folks who are immunocompromised, you can give them as many doses of vaccine as you want, and they won't mount a good immune response. So what you have to go to is what's called passive immunization, and that's where, preformed antibodies get injected into the body, and that's what happens with the monoclonals. There's really good data for both immune competent and immune compromised people that if they have monoclonals on board and they get exposed to COVID, they're protected. What we don't is, if they get exposed and get monoclonals, even if they're not symptomatic or don't test positive, they're protected. What we don't have real good data on yet is the pre-exposure prophylaxis. The one study that's been done was by Astrazeneca, which showed efficacy of pre-exposure prophylaxis. So you just get your monoclonals on board, and then you get exposed, and your safety is quite good. And so, as you pointed out, the FDA just issued an emergency authorization for pre-exposure prophylaxis of the Astrazeneca monoclonal. Bad news. Monoclonals are really finely tailored to specific antigens. much more so than the immune response you get from vaccines, which is much more broad. So when you get a mutant like Omicron that really hammers the sensitivity to antibodies, probably the monoclonals are going to get hit first. And so I think the Astrazeneca vaccine may have been approved, just a little bit too late.
Astrazeneca monoclonal.
Yeah, the monoclonal.
It may have been. It would have been nice to have 90 days ago. We're not so sure it's going to be as helpful
Right.
now, but it does foreshadow that there's bound to be other ones that could be used in exposure prophylaxis.
And
so it's just EUA authorized. Nobody has any of this in their hands yet. We will get it as soon as we can. Again, if you are in that category, that's a clear-cut discussion you should be having with your physician. I mean, if you're a transplant patient and you've been vaccinated 4 times and you still haven't mounted antibodies, that's a discussion with your physician. I can say no question based on the data short term, it's going to be a good decision. But if Omicron replaces Delta in 4 to 6 or 8 weeks, we're not sure it's going to have a lasting improvement.
It may not be as good as hoped, but we've requested a supply from the state, and we're waiting to get a shipment.
I'm going to wrap up with 2 very specific questions. One is somebody who attended a large gathering, lots of babies, very little kind of societal protection going on, and of course those kids younger than 5 can't be vaccinated. So how risky is that is really the question. And this is an important question as we all get into holiday gatherings and other things. And so I'm going to show you a slide I shared with you last time. And this is the deaths among children by age. And if you remember, what I pointed out was that, we just authorized this to 5 to 11-year-olds, and they actually have the lowest death rate of any group of children. They had the highest rate of the MIS-C, but the lowest death rate, but that still urging people to protect those children, but very importantly to protect their siblings, because many of those children or the friends of those children, etc., when you look at a school environment, have a 1-year-old sibling, a 6-month-old sibling, etc. And unfortunately what you see is a pretty significant level in younger infants. So my general answer is those are individuals you should be protecting very significantly. Breastfeeding, like with most potential infectious diseases for young children, passes maternal antibody on. If you're breastfeeding, obviously, that doesn't typically go all the way the 12 months, but you can protect the youngest there with that. And alternatively, you really do have to think about those strategies, especially if we do see Omicron. And, remember in South Africa, as Dirk pointed out, we're seeing more 0 to 5, and they're not a vaccinated society, so that's probably not fully a vaccine access issue. And so we're going to have to watch that issue for sure. And then finally, a very specific question about travel. Look, I'm traveling. Others are traveling. There are smart ways to travel. Obviously on airplanes and others, use protection, especially as Omicron's going to come up, because, as Dirk was talking about, we're seeing evidence that it is wildly infectious. So I would be wearing an N95, possibly eye protection in addition, even if you haven't been doing that over the last couple months as you travel. This one's about cruises. Cruises are one of the toughest infectious environments out there. We know that in general. It also asks about some specific countries. There's nothing about those specific countries that gives me any concern other than maybe getting positive and getting stuck there when you would rather be here. So you just have to think about this. It goes back to that, look at your own individual risk. If you're 30 years old, you're boosted, you're going to use some protections. You're going to be lower risk, but you have some risk. If you're an 80-year-old going on a cruise, you really should be thinking twice about that, especially right now at this point in time. So with that, we've gone over, but we wanted to catch everybody's questions and answer each and every one of them. I want to end today with huge holiday wishes for everybody. Gratitude to each of you for the support you've provided to our institution. Dr. Weinstein talked about how hard it has been for the healthcare employees, and it has been, but the community support has been so incredibly meaningful. So I want to thank each and every one of you for that. We will continue these series on into 2022. My goal is to have more Dr. Weinstein and less Dr. Sostman and less me, or more others like Dr. Weinstein. But doggone it, we did a good job of that last month, and then Omicron came. I do want to say special thanks to both Ashley Drews, who today, and David Bernard on other occasions have been in the background. You don't see them here, but they are directly answering questions fast and furiously throughout the time of these. I want to thank, this is the wonderful DeBakey studio. Actually, it was Alan Lumsden, our chair of cardiovascular surgery vision, and we kind of co-opted it a little bit here. And you don't see them, but I'm looking at a couple here, and then some through the control room, a group of amazing people who have worked really hard to bring these to you and done that so professionally. So maybe y'all could all give some virtual applause to each of them. They deserve it. I do want to point out that we'll be back in this studio as well as other sites next week. Many of you are members of the Society for Leading Medicine, and we have a wonderful annual event. We've done so many nice events with the Astros and the Texans and the ballet and others. Last year we did a really neat one virtually. If you remember with NASA, we are doing a great virtual event this year with the Houston Ballet next Tuesday afternoon. So if you'd like that, let us know. Send us a note if you haven't heard about it. If you haven't joined the Society, we'd love to have you as a member. But most importantly, have a wonderful, joyful holiday season. Let's have a much better 22 than 21, and most importantly, stay safe. Follow the things we all know that can keep us safe, and God bless each of you. Thank you.